Jaundice. Of course, we will discuss this in pediatrics, general medicine, many places, but at least from a pathology perspective, let us touch base some of the key concepts of jaundice. Jaundice can be direct, conjugated hyperbilirubinemia, where conjugated bilirubin is soluble in water. Unconjugated bilirubinemia, which is called indirect bilirubin, which is not soluble in water. When will you see icterus or scleral discoloration and clinically observable jaundice? Only when the bilirubin levels are more than 3 milligrams per deciliter, first time clinically it become evident. This value 3 milligrams is a favorite ward round question. How many milligrams should be there for jaundice to be visible? 3. If there is a hemolysis, indirect bilirubin, which is unconjugated, will be elevated. Then any impaired conjugation, whether it is due to any liver problem like hepatitis, or if there is any congenital deficiency of the glucuronyl transferase, can lead to unconjugated hyperbilirubinemia. As a pediatrician, tomorrow when you need to grade the jaundice, if the jaundice is restricted only to the face and part of the trunk above the level of the umbilicus, you call it as bilirubin less than 12. And whose palms and soles are yellow, then the serum bilirubin is considered to be more than 15 mg per deciliter. To differentiate whether what type of jaundice it is, simple clinical examination is urine examination. So what is the starting point in the urine examination? Urine urobilinogen. Suppose if it is increased, urine urobilinogen. What does it mean? Probably there is either a hepatocellular injury, hepatitis, or there may be hemolysis, whatever that, either of the two, and that is causing a lot of unconjugated bilirubin to be produced, and that is basically entering into the gut. Then it is converting into urobilinogen, and urobilinogen is appearing in the urine. That's what you will basically conclude. So what is the story? Why urinary urobilinogen will be positive in hemolysis and hepatocellular jaundice? Unconjugated bilirubin will enter into the gut and convert into urobilinogen, which will appear in the urine. This is the underlying cause. Then you need to know what is the correct underlying cause between the two. Check the bilirubin value directly. Suppose if it is absent, that means it is unconjugated bilirubin, because unconjugated bilirubin directly is not dialysable. It cannot enter into urine. Directly, I am not talking about urobilinogen. When will urobilinogen will come into picture? Any bilirubin from the liver should go into gut and convert into urobilinogen, which whether that urobilinogen forms from conjugated and unconjugated doesn't matter. It will appear in urine. Suppose if it is obstructive jaundice, then the bilirubin cannot enter into gut. So it can't convert into urobilinogen. Hence urinary urobilinogen will be negative. So a negative urinary urobilinogen means obstructive jaundice. A positive urinary urobilinogen means bilirubin, we don't know whether it is conjugated or unconjugated, we don't know, but it is able to enter into the gut. That means it is not obstructive. Not obstructive means either it is hemolytic or it is hepatocellular jaundice. But hepatocellular jaundice lead to conjugated, and the hemolytic jaundice is typically unconjugated. Only if it is conjugated, bilirubin can enter into urine. So that is the reason in case of the hepatocellular damage, you will find the presence of the urinary bilirubin, which is conjugated. Whereas it can't be able to enter into urine in case of unconjugated bilirubin in case of hemolytic anemia. In the first test, if the urobilinogen doesn't appear into urine, that means there is an obstruction which is a obstructive jaundice. Okay, doctor? Now, what lead to conjugated hyperbilirubinemia? A very important question. Any reduced hepatic excretion, manufacturing of the conjugated bilirubin happened in the liver, but liver don't know how to excrete. That can lead to storage of the conjugated bilirubin, which is synthesized within the liver only, it remained. From the liver it jumped directly into plasma, leading to conjugated hyperbilirubinemia. Any bile duct obstruction, then if the bile duct is obstructed, bilirubin don't know how to go into gut, obstructive jaundice. Then also it becomes stagnated in the liver and it will slip into blood directly and lead to conjugated hyperbilirubinemia. Neonatal jaundice, let us talk few things about it. In the first week of life, classically we have the neonatal jaundice, and originally mild, transient. And what type of jaundice is neonatal jaundice, doctor? Unconjugated hyperbilirubinemia. So why in this small baby it is happening? Because in this baby, the glucuronide transferase system has not yet matured in the liver, leading to this unconjugated hyperbilirubinemia. How do you treat him? Basically, you will be exposing him to the ultraviolet light. What will that ultraviolet light will be doing? It will converting that unconjugated bilirubin from a insoluble isomer into a soluble isomer, so that its excretion become speeded up. So that is the idea of treating neonatal jaundice. Then hemolytic disease of the newborn. If there is any RH incompatibility, then this can occur. It's very dangerous, and if you compare with that of the neonatal jaundice, the amount of the bilirubin rise in the case of the hemolytic disease of the newborn will be quite higher is what you need to appreciate. Then breast milk jaundice. Typically in the breast milk you have a lot of substances which will prevent the proper conjugation of the bilirubin. So breastfed newborns usually after the first year will develop this breast milk jaundice, which will lead to prolongation of the physiological jaundice. Basically is a type of presentation. Then what is Gilbert's and Figler-Naser? Let's be very sure. Typically Gilbert, isolated hyperbilirubinemia. That means only bilirubin is elevated, AST, ALT, alkaline phosphatase, everything is normal in the liver function test. You call it as Gilbert. It is also unconjugated hyperbilirubinemia. Only incidentally you will discover. Patient will be exercising, patient may have stress, patient may have fever, patient may be dehydrated. In such guy, when the LFT is done, only bilirubin elevated but nothing else, alkaline phosphatase, AST, ALT, everything is normal. Then you consider the possibility of Gilbert. So basically what is the problem in the Gilbert? Why it is unconjugated? Because bilirubin need to be taken up by the hepatocytes for it to be conjugated. So that uptake defect is the underlying cause of the Gilbert. Crigler-Naser. This also leads to unconjugated hyperbilirubinemia. There are two types, type 1, type 2. Be very sure, type 1 is complete deficiency, absence, type 2 is partial. There are other conditions in medicine where type 1 will be partial, but don't confuse for those conditions. I still remember in one of the state MD entrances losing a mark just due to type 1, type 2 issue, which is partial, which is complete. So what will you remember? Type 1 is complete. Type 1 is complete is what you need to, complete absence I mean to say, is what you need to remember. Yesterday we discussed von Willebrand disease, do you remember? Between type 1 to 3, which is complete absence, type 3 there. But type 1 is partial. But in case of Crigler-Najjar, type 1 is complete absence, type 2 is partial. Tasman jagrata in the exam. So, type 1 uniformly fatal. Since type 2 there are few glucuronide transferase enzymes, you can increase their amount by using a P450 inducer like phenobarbital, then the jaundice will come down. Then kernicterus is a real complication whenever you are having bilirubin excess, where basal ganglia, hippocampus, subthalamic nucleus, in all these areas there can be deposition. Then what is Dubin-Johnson? With a great difficulty, bilirubin got conjugated. But in Dubin-Johnson, that conjugated bilirubin need to be vomited out by that hepatocyte. Secretion should be done. Then only it can enter into biliary canalicular system and go into the intestines. Secretory defect will lead to that conjugated bilirubin remain in the liver and lead to deposition in the liver, leading to black pigmentation of the liver, which is called piggy liver, is a description of Dubin-Johnson. Then typically what is meant by now let us talk about the physiological jaundice and Crigler-Najjar. Basically impairment of conjugation is the problem in both of them ultimately. Now doctor, black pigmentation and Dubin-Johnson should not be basically forgotten. So that is all the story that we need to know about the jaundice, doctor.